The following podcast is part of a certified educational activity titled Expanding the Benefits of Checkpoint Inhibitors and Targeted Agents in the Treatment Arsenal for Triple-Negative Breast Cancer. Access the entire activity and complete the post-test at peerview.com/EKR860. Downloadable slides and practice aids are also available.
Hi, welcome to this, I hope, very useful symposium today called Expanding the Benefits of Checkpoint Inhibitors and Targeted Agents in the Treatment Arsenal for Triple-Negative Breast Cancer. I'm Joyce O'Shaughnessy. I'm glad to be your moderator today, and I hope that you'll find this post-ASCO discussion very useful for your practice. This is sponsored by PeerView Live, a CME program today. And it's my great pleasure to introduce our faculty, Dr. Rita Nanda from the University of Chicago and Dr. Priyanka Sharma from the University of Kansas. And I'm Joyce O'Shaughnessy from Baylor, Texas Oncology, and U.S. Oncology in Dallas. And we'll be focusing on triple-negative breast cancer, both early stage and metastatic disease today. Before we begin our presentations, let's briefly focus on the key theme from ASCO this year, disparities in cancer cure. And we'll look at disparities in breast cancer, clinical care, and research. And to do that, we're very fortunate that the Tiger Lily Foundation has partnered with us in this program to bring in the patient perspective and shine a light on disparities in breast cancer, clinical care, and research. And the Tiger Lily Foundation was founded by Mayma Carmo. Mayma is founder and CEO of the Tiger Lily Foundation, and she is a 15-year survivor of TNBC.
Hi, I'm Mayma Carmo, a 15-year breast cancer warrior. When I heard the words, "you have breast cancer," my life changed, and I had to think about how to save my life, but then also how to ensure other women had access to the right kind of treatments in time, and how to help them be their best advocates as well. So while in treatment, laying in bed, going through chemotherapy, I began a nonprofit that's grown called the Tiger Lily Foundation that helps to educate women of color, women of all colors actually, but those who are facing cancer at a higher risk, who are women who are dying of the most of breast cancer, young women, and brown and black women. So our mission is to educate, advocate for, empower, and support women going through breast cancer, and to ensure that we work to end disparities of age, stage, and color in our lifetime.
We know that there are disparities in the outcomes for patients. In this case, for example, Black African American women. Black women have lower rates of diagnosis of breast cancer than white women, but are diagnosed at a younger age, at later stages, with more aggressive forms like TNBC, about 21%, and have the highest death rate. Let's hear from Jamil, who was diagnosed with metastatic breast cancer at the age of 39 and encountered many barriers.
Black women die of breast cancer at a 40% higher rate than white women. The narrative was, oh, well, it's personal responsibility. They just don't have enough money. Then it was access to healthcare as to the reasons why, we have these disparities. However, what was interesting, though, is that in those areas where all things are equal as far as treatment, insurance, and those things are not a factor, that they still had disparities in their survival outcomes.
Racial and ethnic minorities are more likely to experience delays in therapy, less likely to obtain adequate treatment, and are also significantly underrepresented in clinical trials. Let's hear from Lori, a patient with breast cancer who was fortunate to benefit from a clinical trial.
What we know about clinical trials is that not enough Black women are in clinical trials. Less than 10% participate in clinical trials. We know that when we look at the statistics, it's about being asked, it's about being considered. I know that with this diagnosis that it is an opportunity for me to give a voice, to give a platform to women that look like me, that may not have that opportunity.
As we heard in Dr. Lori Pierce's presidential address at ASCO, not only do we need to define and describe the disparities, she said we have to be called to action. Equity for every patient, every day, everywhere, and she called us to action, to take meaningful action individually and jointly to acknowledge and overcome disparities in breast cancer clinical care and research. Let's again hear from Mayma Carmo, founder of the Tiger Lily Foundation.
So what I want to leave you all with today is this, that as a provider, you are your patient's best advocate. The healthcare system is very complex, and right now we're dealing with multiple challenges with COVID and cancer. But the thing is that you went to medical school for a reason and took an oath to be that person who's there for your patient. So each patient you meet is an individual person with their own challenges in their life and their cancer care. And your job is to make sure they have access to the high quality, equitable care throughout their cancer journey. And so I'm calling on you today to ensure that everyone you meet, every patient you meet, you have the power to change that person's life and work with them in a way that's actionable to ensure they have quality care throughout their cancer continuum.
So that was just a very, very important theme at ASCO this year, really defining, describing, and beginning to address disparities across the cancer continuum. And now we're going to turn to updating all the key data for early stage and metastatic TNBC with expert perspectives on how to make the most of the latest treatment advances in metastatic and early stage TNBC. And with that, it's my great pleasure to turn us over to Rita Nanda, who will talk about immunotherapy advances in TNBC.
Thank you so much, Joyce, and it's my pleasure to be here today to provide an update. I'd like to start just by reminding everyone why we began investigating checkpoint blockade therapy for triple-negative breast cancer first. And there were a number of observations that have been made in the past 10 years that have suggested that of all the different subtypes of breast cancer, that triple-negative breast cancer is the breast cancer subtype that's most amenable to immunotherapy. We've seen from a number of studies now that triple-negative breast cancer is the most likely form of breast cancer to have a high degree of tumor-infiltrating lymphocytes, so more likely to have that inflamed tumor microenvironment where we know checkpoint blockade can be most effective. We also know that triple-negative breast cancers are more likely to express PD-L1 and also are generally more genomically unstable than the other forms of breast cancer and can be characterized by a higher degree of non-synonymous mutations that can actually elicit an immune response. And that's really the rationale. That, coupled with the high unmet clinical need to identify novel treatment strategies for triple-negative breast cancer. We started by a number of relatively small monotherapy trials because we wanted proof of concept. We wanted to see if these agents by themselves could be effective for the treatment of advanced triple-negative breast cancer. And while the response rates are quite modest in the metastatic setting, we've seen proof of concept. We know that checkpoint blockade as monotherapy can work for a small segment of patients with triple-negative breast cancer. And what we've observed from some of these monotherapy trials have helped us build on this early success. What we've seen from the atezolizumab and pembrolizumab monotherapy experience is that line of therapy matters. The earlier that checkpoint blockade therapy is incorporated into the management of patients with metastatic triple-negative breast cancer, the more likely it is to work. Response rates are in the mid-20% range if these agents are given in the frontline setting, as opposed to under 10% in subsequent lines of therapy. We've also been able to make a number of other observations as well in conjunction with a line of therapy. Those tumors that are characterized by a high level of tumor-infiltrating lymphocytes and are PD-L1 positive are also more likely to benefit from checkpoint blockade monotherapy. And when we look at those patients who received checkpoint blockade in the frontline setting, have a robust immune infiltrate within their tumor, and have PD-L1 positive disease, we can see that response rates approach 40%, which is really quite remarkable. And what we've also seen from the Keynote 119 trial, which was just published earlier this year, to remind you, Keynote 119 was a randomized phase 3 trial, which enrolled patients with advanced triple-negative breast cancer who'd had 1 to 2 prior lines of therapy for metastatic stage disease. And these patients were randomized to pembrolizumab monotherapy versus chemotherapy of physician's choice. While the trial overall was a negative trial, there was no significant improvement to pembrolizumab over chemotherapy. There were some subset analyses that showed some patients with triple-negative breast cancer do actually seem to do better with pembrolizumab therapy. Those patients who have a high tumor mutational burden, defined as at least 10 mutations per MB, also a higher degree of PD-L1 positivity, so a combined positive score of 20% or greater, those patients seem to benefit from pembrolizumab over chemotherapy. Obviously, these were subset analyses and underpowered, but are giving us some clues to perhaps a subset of patients who may benefit from checkpoint blockade therapy without chemotherapy. So why are we so excited about checkpoint blockade therapy? While certainly it is a minority of patients who seem to benefit from monotherapy, those patients who do benefit can benefit for a very long time. And a very small subset of patients are perhaps even cured of their advanced stage triple-negative breast cancer with treatment with either of these agents. And that's not something that we've generally thought about when we think about metastatic disease. So again, that's the excitement, and much of where the field is heading is what can we do to help more patients with advanced triple-negative breast cancer benefit from checkpoint blockade therapy. And as you all know, there are many, many combination trials that are ongoing, targeted therapies in conjunction with checkpoint blockade strategies, chemotherapy, radiation therapy, a whole host of different therapies. But as chemotherapy is the mainstay of treatment for advanced triple-negative breast cancer, and because we've seen benefits to chemotherapy in this space, combined with the knowledge that some of the chemotherapy drugs we use to treat breast cancer are actually quite immunogenic, that led to a number of the randomized phase 3 trials looking at chemotherapy with or without checkpoint blockade therapy. The Impassioned 130 trial was the first randomized phase 3 trial to be reported. This trial enrolled patients with advanced triple-negative breast cancer. These patients could not have received prior therapy in the advanced cancer setting. And if they had received therapy for early stage disease, had to have a year disease-free interval. Patients were eligible regardless of their PD-L1 status. And patients were randomized in a one-to-one fashion to nab-paclitaxel with atezolizumab or nab-paclitaxel plus placebo. The co-primary endpoints of this trial included progression-free and overall survival in the overall population, as well as in the 40% of patients who had PD-L1 positive disease. And there were a number of secondary endpoints as well. And you can see here the results that led to the FDA accelerated approval of the combination of atezolizumab and nab-paclitaxel for patients with PD-L1 positive triple-negative breast cancer. There was a modest but significant 2.5-month improvement in progression-free survival. And while not able to be statistically evaluated, there was a clinically meaningful improvement in overall survival. Because of the hierarchical nature of the statistical design, when the intent to treat overall survival benefit was not seen, it could not be assessed for statistical significance. But again, I would argue a very clinically meaningful 7-month improvement in overall survival for those patients with PD-L1 positive triple-negative breast cancer. And at this ASCO meeting, we've seen some updated biomarker data from Dr. Emmons, which suggests that it is truly only those PD-L1 positive patients who benefit, but within those PD-L1 positive patients, that perhaps the molecular subtype also factors in, with the basal-like immune activated PD-L1 positive patients having the most robust improvement in progression-free survival and overall survival. So it'll be really interesting to see similar analyses done in the early stage setting. The Impassioned 131 trial, which was presented at ESMO last year, was a similar trial to Impassioned 130. However, in this trial, it was paclitaxel that was the chemotherapy backbone. And you can see, interestingly, this trial was a negative trial. There was no improvement in progression-free survival or overall survival to the addition of atezolizumab to paclitaxel chemotherapy, regardless of PD-L1 status. I think it remains to be seen why this trial was negative. Some suspect perhaps it's the chemotherapy backbone, the need for steroid premedications with paclitaxel, but I think it will also be interesting to see what the biomarker work tells us about this trial. But at the present time, there is no role for the combination of paclitaxel with atezolizumab for PD-L1 positive advanced stage triple-negative breast cancer. The Keynote 355 trial was a similar trial, a randomized phase 3 trial, in this case using pembrolizumab with chemotherapy versus chemotherapy and placebo in patients with advanced triple-negative breast cancer who'd not received prior therapy for advanced stage disease. A little unlike the Impassioned 130 trial, this trial allowed patients to have a disease-free interval of just 6 months. And the reason for that is that there were different chemotherapy backbones that were investigated in the context of Keynote 355. Here, the chemotherapy could be paclitaxel, or the combination of carboplatin plus gemcitabine. And again, very similar dual secondary endpoints of demonstrating a progression-free survival and overall survival advantage in those individuals who participated in the trial in the intent to treat population, as well as in those patients with PD-L1 positive disease. And you can see here a summary of these results that have been previously presented. We saw a very clinically meaningful and statistically significant improvement in progression-free survival for those patients with PD-L1 positive disease, here defined as a combined positive score of at least 10. We also saw a significant improvement in response rate, as well as a remarkable improvement in duration of response, more than 1 year improvement in duration of response over chemotherapy alone when pembrolizumab was added into the equation. So this Keynote 355 trial has led to the accelerated approval of pembrolizumab in conjunction with chemotherapy, and here there are a number of potential chemotherapy partners: paclitaxel, nab-paclitaxel, or carbogem. In a subgroup analysis, it actually was shown that even for those patients who received paclitaxel in the context of Keynote 355, there was an improvement with the addition of pembrolizumab. So a little bit different than what we've seen in Impassioned 131. However, it was a pretty small subgroup of patients who received that therapy. But again, with pembrolizumab, a variety of different chemotherapy backbone partners. Shifting gears to talk a bit about the early stage setting, there were 2 large randomized phase 3 trials that have been reported to date, the Keynote 522 trial, as well as the Impassioned 031 trial. Both of these trials looked at the addition of both neoadjuvant as well as adjuvant checkpoint blockade therapy to standard of care chemotherapy. In the Keynote 522 trial, that chemotherapy backbone was paclitaxel plus carboplatin, followed by anthracycline-based therapy. And for the Impassioned 031 trial, it was nab-paclitaxel followed by AC chemotherapy. In both of these trials, there was a significant improvement in pathologic complete response rates for those individuals who were randomized to receive either pembrolizumab or atezolizumab as part of their neoadjuvant regimen. And unlike the metastatic setting, PD-L1 positivity didn't really seem to predict for who was most likely to benefit from the addition of checkpoint blockade. So certainly more biomarker work is needed here in this space to identify who are those subset of patients who benefit from the addition of checkpoint blockade to standard neoadjuvant therapy. An update, as well as a recent press release regarding the Keynote 522 trial, what we learned is that at the time of the initial presentation at the interim analysis number 1, there was already a separation of the event-free survival curves favoring the pembrolizumab arm. What we saw at the ODAC meeting a few months ago was that there continued to be a nice separation of the event-free survival curves. And most recently, we've seen a press release, although we have yet to see these data, that Keynote 522 has met its dual primary endpoints of demonstrating not only a significant improvement in pathologic complete response, but also an improvement in event-free survival. So I look forward to seeing these data at an upcoming Congress, likely ESMO this year, and potentially an indication for this pembrolizumab in the neoadjuvant space. What we've also seen at ASCO this year is an update of the GEPAR-Nuevo randomized phase 2 trial. As a reminder, this was a trial which enrolled early-stage triple-negative breast cancer patients, stage 2 to 3 disease, and they were randomized to receive durvalumab in conjunction with standard of care neoadjuvant chemotherapy, nab-paclitaxel followed by EC, or a placebo. Early on in the course of this trial, there was a window phase where patients were randomized to durvalumab or a placebo for a 2-week period prior to the initiation of chemotherapy. Because of ethical concerns, this window trial was closed after a period of time, and patients were then subsequently started with chemotherapy right away. What the window trial has shown us is, at least has suggested that is there a role for starting neoadjuvant durvalumab or checkpoint blockade therapy prior to the combination of checkpoint blockade therapy with chemotherapy? Because interestingly, in this cohort study, in this window cohort portion of the study, there was actually a greater numerical improvement in pathologic complete response rates as compared to those patients who started with combined checkpoint blockade therapy and chemotherapy. Although this was a small study and it's hard to draw any conclusions, while the trial did not meet one of its primary endpoints of demonstrating a significant improvement in pathologic complete response rates, although you can see there was a numerical advantage to those patients who received durvalumab. What we've seen at ASCO this year is that those patients who were randomized to durvalumab actually had a significant improvement in their 3-year overall survival. So again, like what we've seen from Keynote 522, and now from GEPAR-Nuevo, the addition of checkpoint blockade therapy to neoadjuvant chemotherapy for triple-negative breast cancer seems to not only improve pathologic complete response rates, but also improves long-term outcomes, which is obviously very exciting to see as we think about how to move this forward for our patients. I'd also like to mention briefly a couple of trials that are ongoing now. The Impassioned 030 trial, which is an adjuvant trial for patients with early-stage triple-negative breast cancer, stage 2 to 3 disease who've undergone surgical resection. Patients in this trial are then subsequently randomized to paclitaxel plus AC with atezolizumab or with chemotherapy alone. After the completion of adjuvant chemotherapy, then patients go on to receive atezolizumab in the extended adjuvant setting. The primary endpoints of this trial are invasive disease-free survival in this overall intent to treat population with a number of secondary endpoints. Another trial, I think, which many of us are participating in is the SWOG 1418 trial. And this is an adjuvant trial for patients with early-stage triple-negative breast cancer who do not achieve a PCR with their standard of care neoadjuvant therapy. For those patients who have residual disease, they're randomized to a year of adjuvant pembrolizumab or a year of observation. And this study is nearing its enrollment goals, and hopefully in the not too distant future, we'll see if there's a role for adjuvant pembrolizumab for those patients who don't achieve a PCR with standard of care therapy. I'd also like to mention briefly that there are a number of different assays that are being used in the context of these metastatic trials to determine PD-L1 positivity. A number of different antibodies, the SP142 Ventana assay, which has been used for the Impassioned trials, and the 22C3 assay, which has been evaluated in the Keynote trials. And Also, there are different compartments of the tumor that are being evaluated in assigning PD-L1 positivity. For the SP142 assay, it's limited to the immune cells in the tumor microenvironment. For 22C3, it's a combined positive score, which takes into account tumor PD-L1 positivity as well as immune cell positivity. And I'd like to point out that while there is a fair bit of overlap, these are not equal in terms of assigning or assessing for PD-L1 positivity. So I think there's a lot of work that remains to be done in the biomarker space for figuring out how to best use checkpoint blockade therapy in both advanced and early stage triple-negative breast cancer. I'd like to end briefly just by commenting on some of the toxicities that are seen with checkpoint blockade therapy. Obviously, we can see immune-related adverse events involving just about any organ. For the vast majority of patients, these are generally mild and easily managed. But for some patients, these can be severe, irreversible, and life-altering or life-threatening. So it's a real delicate balance that we play in stimulating an anti-tumor immune response while also not allowing for unchecked immune responses that actually attack the normal organs. And you can see here any organ in the body can be impacted by checkpoint blockade and autoimmunity. You know, most of these are managed with immunosuppressive therapy, but many of these, particularly the endocrinopathies, can be irreversible and can affect quality of life. And as we think about moving these agents into the early stage setting, we really need to be very thoughtful about who are the patients who benefit the most from these therapies so that we can prevent those patients who aren't going to benefit from experiencing some of these serious life-altering and life-threatening toxicities. I'd also like to point out that these immune-related adverse events can occur at different times. Rash and diarrhea are generally among the early immune-related adverse events that are seen, whereas the endocrinopathies and other organ involvements, including the liver and the lungs, occur at somewhat later on. But as we think about novel combination strategies, this timeline can be very variable. And it's also important to recognize that patients can experience immune-related toxicities months and even years after exposure. So it's always important to think about these potential toxicities as we're continuing to take care of our patients. I'd like to point out that it's also very important to engage with a multidisciplinary team to help manage these immune-related toxicities. I think many institutions and organizations are identifying individuals who have expertise or interest in helping to manage these toxicities. And it's really important to recognize these toxicities early and get these patients in to see the subsequent subspecialists for aid in management. So just to summarize very briefly what I've talked about, atezolizumab and pembrolizumab are both now FDA approved for PD-L1 positive triple-negative breast cancer. It's important to recognize that the companion diagnostics for the approvals are different between these two agents. In the early stage setting, we've seen that both pembrolizumab and atezolizumab are associated with a significant improvement in pathologic complete response rates. And there's emerging data from Keynote 522 as well as Gepar-Nuevo that pembrolizumab and durvalumab in the neoadjuvant setting is associated with an improvement in long-term outcomes, which is really very exciting to see. PD-L1 positivity is not a useful biomarker in this early stage setting, so there is an urgent need to identify who are the patients who are most likely to benefit from these strategies. And it's important to recognize immune-related adverse events, not only in those patients with metastatic disease, but as we're now potentially moving these agents up into the early stage setting, that we recognize these early and we manage these toxicities. And multidisciplinary management is key. I'd like to end just by a case for you to consider. Miss CC is a 42-year-old Haitian woman who was initially diagnosed with a clinical T2N1 triple-negative breast cancer. She was treated with neoadjuvant chemotherapy with taxane and anthracycline-based treatment. She went on to receive a partial mastectomy and a sentinel node biopsy and was found to have a pathologic complete response. She went on to receive adjuvant radiation therapy, But unfortunately, 1.5 years after completing therapy, she self-palpated a contralateral axillary lymph node. A biopsy was positive for recurrent triple-negative breast cancer, and a metastatic workup revealed multiple pulmonary nodules, as well as hilar and mediastinal lymphadenopathy. Next-generation sequencing was performed. There were no actionable alterations. She'd previously been tested negative for BRCA1 and 2 germline mutations, and her tumor was sent for PD-L1 testing, and she was found to have PD-L1 positive triple-negative breast cancer. So I'd like to ask you, what treatment would you recommend for this patient? She was my patient, and she was subsequently started on carboplatin plus gemcitabine with pembrolizumab, as she wished to preserve her hair and avoid alopecia. After 6 cycles of therapy, she was found to have a complete imaging response. At that point, chemotherapy was dropped, and she's been continued on pembrolizumab monotherapy. She currently remains in complete response after 12 cycles of therapy.
Wow, what a great case, Rita, and thank you for bringing in all the new data from ASCO into your really well put together talk. Wonderful, wonderful talk. So we love these patients, that get into a CR and then go on with single agent checkpoint, with the hope that they may be the exceptional responders that you've described so well in the work you've done. So one of the questions that came in from some of our participants who had sent in some questions for us is, what do we know about these exceptional responders? Why do some people do so well? Is there a certain phenotype, genotype that we know about that might predict that your patient here, for example, has done so well?
Yeah, no, I think it's great. I think there was a fabulous talk this ASCO that Dr. Leisha Emmons gave about some of the biomarker work that's being done in the context of the Impassioned 130 trial. And what they did was a really careful looking at PD-L1 positivity, looking at molecular subtyping using the Burstein methodology. And what they found was that for PD-L1 negative breast cancer, regardless of molecular subtype, there was no benefit to giving checkpoint blockade therapy with chemotherapy. What they did find was that for those individuals that had PD-L1 positive disease and the basal-like immune activated subtype, that seemed to be the subtype that benefited the most. So if you think about the Burstein data set, they identified 4 distinct molecular subtypes of triple negative breast cancer. It's a little distinct than the Vanderbilt group and some of the other work that's been done, but the basal-like immune activated, the basal-like immune suppressed, the luminal AR, and the mesenchymal-like. And the mesenchymal and luminal AR, regardless of PD-L1 positivity, didn't seem to benefit from the addition of checkpoint blockade to chemotherapy. A subset of those with basal-like immune suppressed seemed to benefit. And it's work like this that's going to help us identify who are those patients that are most likely to benefit. Now, this is one study. It needs to be validated and expanded, and it's not, I think, quite ready for prime time. But, when you think about those different subtypes, it's the basal-like immune activated that already has the best outcome. Those are the patients who seem to do the best even with just chemotherapy. And so they also seem to be the most likely to benefit from the addition of checkpoint blockade. So there's really a lot of work that needs to be done to bring the others along with us, whether it's novel combination strategies, or other targeted agents that need to be evaluated for these patients. There's still a lot of work to be done. It's, again, a minority of patients who have these exceptional responses. And hopefully, as we continue to study more novel combinations, we'll be able to identify a larger subset of patients who can benefit from such strategies.
But now in the clinic, right now, we really don't send for the Burstein subtyping at this time because we really can't say if they're PD-L1 positive. We really can't say at this moment who wouldn't benefit from a nice response. And so, but the basal-like immune activated probably tend to be those with higher proliferation. They're basal-like. They probably got homologous recombination deficiency. We think, although we'll hear from Priyanka, where are we in terms of assaying that in our clinic? But phenotypically, though, Rita, you've described some exceptional responders in your work. Phenotypically, how do these patients usually present, these exceptional responders?
Yeah. I mean, in my mind, they're usually those patients who have chemotherapy sensitive disease. They're ones who've not relapsed so quickly or are de novo metastatic. They have a tendency to have a high immune infiltration in their tumor microenvironment. So clinically, those are the patients who seem, at least in my experience, to have had these exceptional responses. Also more limited disease, like a lower burden of disease, disease that's really focused in on lymph node involvement and lung involvement. Those with skin and liver metastases don't seem to do as well. So pulmonary involvement, lymph node involvement, that's kind of the clinical features. You know, when I see a patient who's come to me and they've only got nodal involvement, maybe some pulmonary nodules in my mind, and maybe a long disease-free interval, those are the ones that I think that might do the best.
Thank you. And Priyanka, I wanted to ask you, in the first line metastatic TNBC PD-L1 positive patient, how do you go about choosing between a pembrolizumab, one of the regimens, or a atezolizumab regimen for that patient?
So I think a lot depends on what companion diagnostic got done to document the PD-L1 positivity, and most of us are doing one or the other. So if it was the CPS score, I will tend to use pembrolizumab-based regimens, and if it was the Ventana SP140, it'll be nab-paclitaxel with atezolizumab. Sometimes the decision on which test to order is also based on how far the patient is in terms of time from initial curative chemotherapy. The 355 MK355 trial did allow patients that recurred in between 6 to 12 months in the study, whereas the Impassioned study did not allow. So if I have somebody that has recurred in that 6 to 12 month window, I'm more likely to order the CPS test for that individual. And I know of a lot of places that have preferentially decided to go with the one. It just makes it easier on our pathologists and reduces the variability on how we're ordering as a practice on these tests.
Thank you. Thanks a lot. And let's turn now to the early stage TNBC high-risk patients. The Gephardt-Nuevo data were really very interesting because the delta on the PathCR with adding durvalumab to the weekly paclitaxel followed by the EC, the PathCR delta was relatively modest. It was certainly there, but yet we saw kind of a disproportionate positive impact on disease-free, distant disease-free, and trending towards overall survival. So that's reminiscent of the preoperative Keynote 522, where the original evaluation showed about a 13.6% improvement in PathCR, adding the pembrolizumab to the weekly paclitaxel carboplatin followed by AC. But on subsequent analyses with larger and larger numbers in Keynote 522, the delta on PathCR got smaller, as you got into larger patient populations. Yet there's now, we'll wait to see the data, a statistically significant and clinically meaningful impact on event-free survival. So it really brings us now, we also saw in the Impassioned 031, we've seen also a nice trend there on event-free survival, albeit small numbers. So the data are kind of shaping up here that there may be a systemic impact regardless of PD-L1 status. So we don't have any FDA approvals. We don't have anything on NCCN guidelines at this moment, but we're used to this. This is, the data always get ahead of things. So what are you guys doing in your practice now? So Rita, I'll start with you. Have you started to use, outside of a clinical trial, use any of the checkpoint inhibitors preoperatively?
Yeah, no, I have not. And I think it's because up until now, we haven't seen long-term outcome improvements. I've obviously treated a lot of patients in the context of clinical trials. And I will say I've had patients have serious toxicities. I've seen adrenal insufficiency, and it makes you stop and think about, sure, fortunately, my patients have had a PCR, but what if they didn't? What if, I've given them, or even that they are cured of their disease, I've given them a lifelong endocrinopathy that impacts quality and potentially life expectancy. And it's not a benign thing. You know, there are patients who can develop diabetes after exposure. I think that there is an urgent need to identify biomarkers of who those patients are who seem to benefit the most from these agents. As of right now, without an approval, I'm not incorporating this into my clinical armamentarium at this point. Now, I would like to see the Keynote 522 data once it's presented. I think the Gepar-Nuevo data looks really fascinating, and I do think that there is going to be an approval and a role for these agents. But I also hope, as we're thinking about how to incorporate these agents into our clinical practice, we also develop better biomarkers. Some of the work that Alicia Emmons has presented looks really interesting. I hope that some of that similar type of work can be done in the neoadjuvant space, because a nice chunk of our patients are actually cured with chemotherapy alone. And we want to make sure that we're using these agents in patients who are most likely to benefit from them as we consider the potential long-term toxicities we may be exposing them to.
Thank you. Thanks so much, Rita. How about you, Priyanka? What have you been doing in your practice, and will that change at all after ASCO? Or?
So, like Rita, I have also not incorporated neoadjuvant immune checkpoint inhibitors in practice outside of clinical trial, and of course have treated many patients on clinical trials and have been impressed with both the efficacy and the toxicity, like Rita mentioned. And the hard part is the unpredictability of the toxicity. You cannot predict who this will happen to. Also have noticed that, you know, patients who have these extreme toxicities are the ones that have the PCR if they're able to complete the treatment. But I've had a couple of occasions where the toxicity was so severe that we had to stop preoperative treatment after 2 or 3 cycles, and one wondered what would have happened if that patient was able to complete treatment. Fascinated by Gepar-Nuevo data and to see that these agents are having an impact in long-term outcomes, and looking forward to more details on 522. Completely agree with Rita that we do need better biomarkers, and you know, perhaps in addition to interrogating the gene expression signatures, one simple way to look at it is with TILs, tumor infiltrating lymphocytes. We know that tumors that have high TILs are more chemoresponsive, and especially if you have a low clinical stage, you know, no negative status and high TILs, with our good chemotherapy regimens, those PCR rates can go upwards of 70%. But we do desperately need some way of figuring out who are the best candidates for checkpoint inhibitors in early stage setting.
Yeah. Thank you. I will just chime in here. I have been adding the pembrolizumab in a Keynote 522 fashion with a paclitaxel carbo followed by AC backbone in the highest risk patients, you know, bulky adenopathy, you know, patients that you have a very, very strong concern that they're going to have considerable residual disease. So I have been doing that for patients just preoperatively. I've not been adding in the adjuvant until we had more data. You know, we'll have to wait and see the Keynote 522. It's interesting because the Gepar-Nuevo didn't give adjuvant checkpoint inhibitor, but 522 did. But I have been adding it in the very, very highest risk patients. And I think the Gepar-Nuevo will probably continue me on that line, because we do have to weigh out these, can be life-threatening and treatment-interrupting, immune-related adverse events. And so I can only justify doing that at this moment in the highest risk patients. So I'm going to move us along, even though there's so many more things we want to talk about, but I wanted to move us to Priyanka, who's going to talk to us about targeted therapy advances in TNBC, focus on the DNA repair pathway.
Delighted to be here to discuss targeted therapy advances in triple-negative breast cancer with a focus on DNA repair pathway, and also review some of the exciting data presented at ASCO this year. These are the topics that I'm going to cover: approaches to targeting DNA defects, repair defects using PARP inhibitors, platinum compounds, novel combinations, role of PARP inhibitors in patients with metastatic breast cancer, and emerging data of these agents in early stage setting. So it was about 15 years ago, in 2005, that preclinical models demonstrated this concept of synthetic lethality in presence of BRCA1 or 2 mutations. So in presence of these mutations, when a PARP inhibitor is added, the two main components of DNA repair pathway, the homologous recombination and base excision repair, are hampered, thus leading to cell death. And that led to, over a decade-long development of PARP inhibitors for treatment of many cancers, including breast cancer. In germline BRCA associated breast cancer, the Olympia AD and Embraca were the two initial studies that assessed PARP inhibitor monotherapy and compared them to non-platinum chemotherapy of physician's choice in patients with advanced breast cancer. These are the trial designs. They were very similar in their design, slightly different in size, with the Embraca being the larger of the two. And both the trials showed similar results. In both studies, there was statistically significant and clinically meaningful improvement in progression-free survival with PARP inhibitor monotherapy compared with chemotherapy of physician's choice, with the improvement in PFS in the order of about 3 months and similar hazard ratios. Both the trials also demonstrated that the quality of life was improved with oral PARP inhibitor as compared to chemotherapy. We saw the updated extended overall survival results from Olympia AD a year and a half ago at San Antonio. And what that showed is in the overall trial population, there was no improvement in overall survival with PARP inhibitor compared to chemotherapy of physician's choice, although there was some suggestion of benefit in subset of patients who had not received prior chemotherapy for metastatic disease, where the 3-year overall survival was 41% for olaparib versus 13% for chemotherapy. Similar to Olympia AD, in Embraca as well, there was no improvement in overall survival with talazoparib compared to chemotherapy, with an overall survival a little over 19 months in both arms. It is to be noted that 1/3 of patients in the chemo arm received a subsequent PARP inhibitor, compared with only 4.5% of patients in the talazoparib arm. So, by the time Embraca was reaching this stage, olaparib was approved for treatment of germline BRCA-associated breast cancer in many parts that led to this use of PARP inhibitor post-progression. The third trial in this space is the Blockade 3 trial, and that used a different PARP inhibitor called Voliperative. Voliperative is a PARP inhibitor with a weaker PARP trapping potency compared to talazoparib and olaparib, but it is that weaker trapping potency that also makes it more favorable to combine with chemotherapy because it has less hematological toxicity. So in this trial, again, included patients with germline BRCA1 or 2 associated advanced or metastatic breast cancer. Patients were randomized to receive a doublet chemotherapy of carboplatin and paclitaxel, or the same chemotherapy with Voliperative. And we saw these results at ESMO a year ago, which showed the improvement in progression-free survival in the Voliperative arm compared to the chemotherapy arm in the order of 2 months. As you can see from these Kaplan-Meier curves, there's much later separation of these curves as compared to what we saw in the Olympia AD and the talazoparib study. Also remarkable is the absolute PFS of 12 months, 12 plus months in the chemotherapy alone arm in these patients. There was no difference in quality of life measures in this study as seen in the other studies. Again, like the other two PARP inhibitor studies, at the time of initial reporting, there was no statistically significant improvement in overall survival in the Voliperative arm compared to the chemotherapy arm. Also noted here is 44% of patients assigned to placebo had received an open-label Voliperative crossover in this study. So it remains to be seen whether this study can demonstrate overall survival with such high crossover to PARP inhibitor in the chemotherapy arm. The overall survival data from this study, I'm told, is expected sometime this year. So we talked about the role of PARP inhibitors in germline BRCA-associated breast cancer, but there are other DNA repair deficiency or HRD biomarkers besides germline BRCA status that can identify patients that are likely to benefit from this class of drug. These could be germline mutations in other genes in the Fanconi anemia pathway, somatic mutations in these genes, specifically BRCA1 or 2, epigenetic BRCA1 silencing through promoter methylation, gene expression signatures in indicative of HRD, and tumor genomic scar measures, and there are several assays that measure this tumor genomic scar. So TBCRC048 was a phase 2 single-arm study that assessed olaparib for metastatic breast cancer patients who had mutations in homologous recombination-related genes. They either had to be germline or somatic mutations for germline outside of BRCA1 or 2, or for somatic BRCA1 or 2 mutations. What this study showed that in patients with germline PALB2 mutation, there was a very nice objective response rate of 82%. And in those with somatic BRCA1 or 2 mutation, again, very nice objective response rate of 50%. They did not notice any efficacy in other homologous recombination gene mutations, whether somatic or germline. SWOG 1416 was a randomized phase 2 study that assessed cisplatin with or without Voliperative in patients with metastatic triple-negative breast cancer. And this study assessed the efficacy of the combination compared to cisplatin alone in 3 pre-specified subgroups: in patients with germline BRCA mutation, in patients who did not have a germline BRCA mutation or were BRCA-like, or in the non-BRCA-like group. And the BRCA-like group was defined by a priori set of biomarkers, which included the HRD genomic scar, somatic BRCA1 or 2 mutation, BRCA1 promoter methylation, or germline mutations in genes outside of BRCA1 or 2. This trial showed that in patients with BRCA-like breast cancer, which accounted for a little over 40% of the trial population, there was a statistically significant improvement in progression-free survival with the addition of Voliperative to cisplatin, with a hint towards improvement in overall survival as well. So if we look at homologous recombination deficiency in triple-negative breast cancer, it is expected in about 50 to 60% of these patients. About 15% of this is the pure germline BRCA1 or 2 mutation associated homologous recombination deficiency, and very clearly we've seen efficacy of PARP inhibitor in metastatic setting, and we have 2 PARP inhibitors that are approved for these patients. There are ongoing studies that are looking at the combination of PARP inhibitors plus immunotherapy in these patients. What about the rest of the patients that have the homologous recombination deficiency, but it is not derived from germline BRCA1 or 2 mutation? This is kind of multifactorial. Each individual cause probably makes a small element of it. And in these patients, there are ongoing investigations, like I just showed you the data on the efficacy of olaparib monotherapy for germline PALB2 carriers, and for those that have somatic BRCA1 or 2 mutation, and the SWOG 1416 showing the first study to demonstrate that the PARP inhibitors can have efficacy beyond germline BRCA1 and 2 mutation based on an HRD biomarker. More work obviously needs to be done for this subgroup, and we don't really have an approved agent or agents for patients that have HRD without the germline BRCA mutation to use in clinic. A couple of single-arm studies, the Mediola and Tapioca, assessed the combination of PARP inhibitor plus checkpoint inhibitors. The response rates seen in these studies look comparable to what we saw in Olympia AD and Embraca, if you look at cross-trial comparisons with all the caveats of cross-trial comparisons in mind. So on the face value, it appears that addition of immunotherapy may not increase objective response rate that much. And it remains to be seen if immunotherapy can expand the tail of the curve that we see in the PARP inhibitor studies. And there are actually a couple of studies that are assessing this exact question: the combination of PARP plus immunotherapy in a randomized fashion, the KeyLink 009 study, and the DORA study. What about the role of platinums in metastatic triple-negative breast cancer? So TNT study assessed carboplatin versus docetaxel in patients with advanced triple-negative breast cancer that had germline BRCA1 or 2 mutation. In the overall trial, the 2 agents were similar in efficacy, but when assessed by germline BRCA status, what was noted that in patients with germline BRCA1 or 2 mutation, there was a higher progression-free survival with carboplatin compared to docetaxel, whereas those that were germline BRCA wild type, both the drugs had similar efficacy. With p-value that was statistically significant for the interaction test. So that established platinum as preferential chemotherapy for those with germline BRCA1 or 2 mutation and metastatic breast cancer. We've talked about PARP inhibitors in metastatic breast cancer. What about PARP inhibitors in early stage triple negative breast cancer? And this year at ASCO, we saw two exciting results. The plenary presentation by Andrew Tutt on Olympia A or Olympia adjuvant study, and the data on talazoparib in neoadjuvant setting as monotherapy presented by Dr. Litton in the oral abstract session. So let's look at the Olympia A study. This has been simultaneously published in New England Journal of Medicine. This was a very large international effort to assess the efficacy of PARP inhibitors as adjuvant therapy in patients with germline BRCA1 or 2 associated breast cancer. Note that this trial included both patients with triple negative disease and those with hormone positive disease with different criteria and risk thresholds for in both of those individual populations to enter the study. For those with triple negative disease, any non-PCR after preoperative chemotherapy was allowed. In the setting of adjuvant chemotherapy for triple negative disease, the cancer had to be over 2 centimeters or node negative or node positive. For patients with hormone positive disease, they could enter the study with lack of PCR, but required a much higher disease burden in that lack of PCR setting. And for those with adjuvant treatment and hormone positive disease, again, a much higher disease burden and 2 or higher disease was required. The patients were randomized to receive a year of olaparib or placebo. And here are the results. Olaparib improved the disease-free survival for these patients compared to placebo, quite remarkably with an absolute improvement of over 8%. There was also a significant improvement in distant metastasis-free survival of over 7% in olaparib compared to placebo. The overall survival results of this study are immature. The median follow-up at the reporting of these results was about 2.5 years. We can see a trend towards improvement in overall survival with 3.7% absolute difference, but the p-value did not cross the pre-specified threshold based on the interim analysis 1 alpha spending plan for the study. Of course, longer follow-up is required for the study. Here's the forest plot looking at the subgroups, and essentially all subgroups benefited from olaparib compared to placebo. For all of these, you see the point estimates to the left of the line. NeoTALA is the neoadjuvant talazoparib single-arm study in patients with germline BRCA1 or 2 mutation, HER2-negative breast cancer. This trial, although started out with planning to include both triple-negative and hormone-positive, but the data presented at ASCO included only patients with triple-negative breast cancer, included 61 patients. Those with BRCA1 mutation accounted for 80% of the patients, and about a third of patients had stage 1 disease. And what you see is this remarkable PCR rate of about 45% with single-agent talazoparib, which was given for 6 months for these patients. About 16% of the patients discontinued the treatment due to progressive disease and went on to receive other alternative systemic therapy, presumably chemotherapy. 39% grade 3 anemia was noted with talazoparib. So hematological toxicity, specifically anemia, is a known side effect of PARP inhibitors, and about 20% required packed red blood cell transfusion. So even though it didn't have the classic toxicity of the chemotherapy, there were other types of toxicity associated with it. Nonetheless, it's an oral drug and quite provoking data and requires further study. So in summary, targeting DNA repair in metastatic triple-negative breast cancer, single-agent PARP inhibitors, olaparib and talazoparib both lead to improvement in PFS compared to non-platinum chemotherapy for patients with germline BRCA mutation-associated advanced or metastatic breast cancer. Overall survival advantage has not been demonstrated in the 2 large trials, and we await the overall survival data from Blockade 3 study. It is to be noted that PARP inhibitors were not directly compared to platinum in the metastatic trials. And PARP inhibitor plus platinum chemotherapy is under study, is being evaluated in Blockade 3. We await the overall survival data from this study. It also brings to forefront the question of maintenance approach, which is very popular in ovarian cancer, and that's how most of the PARP inhibitor use is in ovarian cancer. You give chemotherapy first and then maintain those responses with a PARP inhibitor. There's emerging data on PARP inhibitor monotherapy efficacy in patients with somatic BRCA mutation and germline PALB2 mutation. And even though these agents are not approved in breast cancer for these two indications, we do have data from other cancers, specifically prostate cancer, where this is an approved indication. So in my practice, if I see these patients, I am trying to get them a PARP inhibitor, even though they don't have the germline BRCA1 or 2 mutation. In terms of single-agent chemotherapy, platinum gives a higher response rate and a progression-free survival compared to taxane in germline BRCA setting. And then ongoing research is assessing PARP inhibitor plus platinum chemo in HRD-positive TNBC beyond BRCA and PARP inhibitor plus IO combinations. In terms of early-stage triple-negative breast cancer, very exciting data from Olympia A, in my mind, practice-changing. With improvement in major endpoints for addition of PARP inhibitor in an adjuvant setting for a year. The PARP inhibitor monotherapy data is very exciting and intriguing and definitely requires further evaluation. Chemotherapy plus PARP inhibitor in early stage breast cancer is being assessed in ongoing partner study, which is a primary endpoint of PCR. Thank you for your attention. I'm going to end this session with a case to consider. This is a 48-year-old woman with T2N0 triple-negative breast cancer who received a neoadjuvant ACT for her primary treatment. She underwent a mastectomy with sentinel lymph node biopsy and was found to have 8 millimeter residual disease and negative sentinel lymph nodes. 18 months later, she develops a liver metastasis, which is detected based on elevated liver function tests. She is a germline BRCA2 carrier. PD-L1 testing done on the original breast biopsy sample shows a CPS of greater than 10%. What would you offer her as a first-line therapy? A PARP inhibitor, pembrolizumab plus carbogem, pembrolizumab plus a taxane, atezolizumab plus nab-paclitaxel or capecitabine. So multitude of options here. This was my patient. I chose to treat her with pembrolizumab plus a taxane, given the PD-L1 positivity, and reserved the PARP inhibitor for second-line setting. I chose a taxane as opposed to a carbogem partner, just because I didn't want her to have prior taxane exposure, perhaps preserving the efficacy of PARP inhibitor for her. And this is also a classic case for where now the Olympia A data would be relevant.
So you wanted to give the PARP inhibitor second line, and so you didn't give the carbogem, you gave the nab-paclitaxel so that you could hopefully preserve the full efficacy of because we don't have a lot of good data. Well, we know in the metastatic setting that the PARP inhibitors are less effective, in the context of a platinum-resistant breast cancer or ovarian cancer. And so that was one of the questions that came in from our participants here, Priyanka. So you're going to start in somebody who's dual germline BRCA and PD-L1 positive. You're going to start with the checkpoint inhibitor data first, presumably because of the survival impact that we have. Would you ever consider stopping the chemotherapy at some point and continuing the checkpoint inhibitor and then adding in as a maintenance therapy a PARP inhibitor in clinical practice at this time? I know it's being looked at in trials, but how about in clinical practice at this time?
I mean, it would be very tempting to do so. Once the chemotherapy is off, and perhaps that would improve the durability of response even further, especially for somebody like her that has liver disease. So it's not those classic cases where you see the long-term responders, the lymph node or the lung disease with immunotherapy alone. And if the insurance would allow it, and we have safety data, plenty of safety data with pembrolizumab and olaparib, I would consider it. And I would try to situate the olaparib before I bring in the platinum, because I do worry about emergence of reversion mutations that affecting efficacy of olaparib or other PARP inhibitors when given in very close proximity.
Yeah, so that the antecedent platinum may lead to a subclone with a BRCA reversion mutation that now is resistant to PARP inhibitors. That's what you're trying to avoid, to get the maximum benefit from the PARP inhibitor. Let's turn to the curative setting if we could, because I want to talk about both the germline BRCA curative setting as well as the wild type curative setting for TNBC. And so, Rita, with regard to the Olympia data, the data are very striking. As Priyanka has shown us, capecitabine was not given to the patients who didn't have a path CR because it wasn't standard of care at that time, but it has become standard of care, and it probably will be that we'll get an FDA approval for a preoperative checkpoint inhibitor. It may be that there's an adjuvant portion of that as well, if it's Keynote 522, for example. So what do you think, because I guess it's, really as soon as we have FDA approval, for the olaparib in the adjuvant setting for the germline BRCA patients, we'll be incorporating it. But what do we do with the capecitabine, and what do we do if we get a checkpoint inhibitor approval as well?
No, I think that's a great question, and it's going to be a really busy space. But I have to say the Olympia data are compelling. And so if I have a mutation carrier, say, who's received immunotherapy in the neoadjuvant setting, so down the road, we've got an approval for immunotherapy in the neoadjuvant setting. And if she doesn't achieve a PCR, I am going to want to give her a PARP inhibitor. I think it remains to be seen, like Priyanka said, we've got safety data of PARP inhibitors and checkpoint blockade therapy. So, it's really interesting, and it's hard to tease out, do we need IO in the adjuvant setting for patients who don't achieve a PCR? I think that remains to be seen. We need to see that data. I absolutely would want to give this patient a PARP inhibitor. And the question of whether or not I would continue checkpoint blockade therapy will be dependent on the data once we see them. But again, we've got safety data for the combination, and we're thinking about patients, and we know that if you don't achieve a PCR, that risk of recurrence is dramatically higher. It's not an incremental sort of increase in risk of recurrence. I would want to pull out all the stops for my patient. I wouldn't want to see a recurrence in someone when we've got these therapies and we think that there's going to be benefit.
Yeah, thank you. Priyanka, I wanted to get your opinion on that too. It sounds like in this population, capecitabine may be deprioritized. The PARP inhibitor will certainly be the number one. If there's a checkpoint opportunity there, if we get an FDA approval, that'll be another question. Do we keep it going in the adjuvant setting, for example? That'll be a question. So I want to get your opinion about how you see this sequencing, but also here's a question. 25%, I guess, of patients in the Olympia had antecedent platinum, carboplatin, let's say, either in the adjuvant or the neoadjuvant setting. Should we be utilizing a platinum, a carboplatin based with a taxane AC in these patients, germline BRCAs, or should we leave it off now because we're going to be using a adjuvant PARP inhibitor?
So, I think I look at that question in two parts. As the patient presents to you and you decide to give preoperative chemotherapy, the goal of that therapy to achieve PCR. So if you achieve PCR, there's much less afterwards, for sure. So I try to optimize, especially in patients with higher clinical risk, my regimen so that I can reach the highest PCR possible. With that in mind, I do include platinum in the neoadjuvant treatment for patients with triple-negative breast cancer, especially if they have a higher tumor size and not positive nodal status. And if they achieve a PCR, then we don't really need to get into discussion of PARP inhibitor or capecitabine and immunotherapy in the adjuvant setting. So the Olympia A did allow prior platinum and stratified for it ahead of time. And you do see, that's one of the subgroups that was hedging a little bit or more on the right of the line, right? So, but again, the confidence intervals around those are so wide. And this is such an early analysis analysis, right? The first interim analysis with such short median follow-up that every subgroup that was small was very unstable. So it remains to be seen whether that exposure reduces the future efficacy of these drugs. And then the balance between that exposure tips another 9, 10, 12% of patients to PCR, then is that worth it? Because then you're not going to be talking about a year of olaparib in these patients.
And that's another question, is in the wild type situation, I hear you say, Priyanka, that you do add the carboplatin, you do a 4-drug regimen pre-operatively, trying to get to that path CR for the patients. And I assume that's, whether or not it's a checkpoint inhibitor. I think the role of preoperative carboplatin has been less clear in the germline BRCAs. The Gephardt-6 dose didn't show that delta on PAF-CR, didn't see it translating into disease-free survival. So there's been a question there about it. But it sounds like, though, you want that PAF-CR, which I think is a really good way of framing these controversies, And so you do it even in the germline BRCA as well as the wild type. I also want to hear from Rita on this too. Is that so? Both Priyanka, both.
So
wild
I
type?
agree that in germline BRCA, the preferential benefit of carbo over adriamycin may not be is not documented. I mean, we've seen AC versus carbo in the INFORM study with equal PCR in the germline carriers. So I don't use that as a criteria to select for carbo in preoperative setting. I have also migrated a little towards non-anthracycline-based regimens with the taxane platinum combinations, especially in those that don't have very, very bulky disease, and reduces the risk of later second leukemias and cardiac toxicity. I do worry about these secondary leukemias and MDSs in my BRCA carriers because they do have inherent predisposition to these second cancers.
Great. And how about you, reading your germline BRCAs or your wild types with regard to the role of platinum?
I don't routinely use platinum as part of neoadjuvant therapy. I think there is a fair bit of toxicity that comes with adding a platinum in that setting. Although I will say doing platinum weekly at an AUC of 1.5 is definitely more tolerable than an AUC of 5 or 6 every 3 weeks. I don't do it across the board. The patients who I do it in are generally young women who have bulky nodal disease or lymph node involvement who don't want to go on a trial. Because my goal there is, we know that platinums don't seem to impact long-term outcomes. But if I can get a young woman with node positive disease and spare her a complete axillary dissection, to me, that's the reason to consider it here. Because I don't want to have a young woman left with, a complete axillary dissection and then struggling with lymphedema. So that's really how I do it. I don't incorporate it across the board. It's more of a case-by-case basis.
Yeah. Yeah, I really agree with you both. I've been using everything I can, basically, in the very, very high-risk patient, including the platinum, the 4-drug regimen, and the checkpoint inhibitor. And I've been doing that regardless of germline BRCA status. One of the questions that came in from the participants is, what do we do in the non-PAF-CR patient? I think the answer is if they're germline BRCA, it's going to be the olaparib. If it's a germline wild type, it's still capecitabine today, right? So that's kind of where we stand right now in patients who don't have a PAF-CR. We await more checkpoint inhibitor analysis and approval by the FDA to see whether we'll be putting the pembrolizumab in the adjuvant setting if Keynote 522 leads to approval, basically. So thank you, guys. Thank you so much for the discussion. I'm going to move us to our last section, and I'm going to talk about ADCs and other novel targets. Really, what I'm going to talk about, the only real practical part of it, are updates on the sacituzumab. But I'll tell you a little bit about other ADCs, where we're going, and other pathways that I think are very important that we do need to target. So what I'm going to talk about are the ADCs, the sacituzumab, and a new 1062, a DATO, a DXD, which I'll tell you about, that also targets TROP2, and ladiratuzumab. So I'm going to go over some ADCs. I'm going to focus on the AKT inhibitor and PI3 kinase pathway. I won't touch on AR because, unfortunately, we don't have any new data to really guide us there. We really need it, but there's still kind of pilot work ongoing combining antagonists, for example, with CDK4/6 inhibitors in the AR-positive triple negative. I will talk at the end just briefly about trilaciclib, which is an IV CDK4/6 inhibitor. Sacituzumab, well known to us all. It's got a bystander effect. It's got a cleavable linker, so all of that loaded up SN38 can fall off in the tumor interstitium and can go across the plasma membrane and the nuclear membrane into a cell next door that doesn't even have that much TROP2 on it. So this bystander effect is very helpful to even kill off cells that may be even zero on TROP2. And we saw on the right in phase 2 a very robust response rate in a very, very heavily pretreated population. And then the phase 3 Ascent trial led to FDA approval. This was third line or later metastatic TNBC, randomized to standard sacituzumab, 10 mg per kg, day 1 and day 8, 21-day cycle, versus one of the 4 chemotherapy agents, eribulin, or one of the beans, capecitabine, vinorelbine, or gemcitabine, with primary endpoint progression-free survival. But the really wonderful thing was this significant improvement in overall survival, a 5.4-month delta, with a survival going from 6 months to basically about 12 months. Only 4.7% of patients discontinued sacituzumab. There is neutropenia, but not much in the way of febrile neutropenia. It's just day 8. Sometimes you end up reducing the dose, not much in the way of diarrhea. There is some alopecia in about half of the patients, but overall manageable toxicity. We've seen some updates of the Ascent trial. This was presented by Sarah Hurvitz at San Antonio last year, asking the question, does it matter what the intensity of staining and the percent cells positive for TROP2 are? So if you look down the bottom left, you see TROP2 high H-score, and we see for survival, there's a huge improvement from 6.9 months to 14.2 months with TROP2 high. And those curves there, the bottom one are TROP2 high in the red with just the chemotherapy physician's choice, and the black line on the top is TROP2 high with the sacituzumab. So that's the biggest difference. But you see in the middle that even with the medium score, we also see that same wonderful, exact same results, big delta on the survival as well in the TROP2 medium. And then even on TROP2 low, we see that there is an improvement in survival. It's not as large, the delta is not as big, but it's certainly better to live 9.3 months than 7.6 months. So the bottom line from this is that we don't have to worry about what the level of TROP2 expression is, and it seems all patients benefit regardless of TROP2 expression. What about older versus younger women? So Kevin Kalinsky at ASCO had an oral presentation from this phase 3 Ascent. On the left, we see the women under the age of 65, and on the right, we see 65 years of age of older. There are about 90 patients in the older group, and we can see that both had a robust improvement in survival. And there was a bit more in the way of neutropenia, a few bit more in the way of side effects for those over 65, but it was true whether they got sacituzumab or chemo physician's choice. A little bit more toxicity, but look at that survival impact. So clearly, older women can benefit just as well from the sacituzumab. This is a very nice piece here from Lisa Carey, again from the phase 3 Ascent. There were 65 women on the Ascent trial. And again, this is the without brain metastasis. That was the intent to treat, without brain metastasis. But they had had a recurrence 1 year or less after their adjuvant or neoadjuvant chemotherapy. These are obviously the most challenging of patients, primary refractory disease. And then they were required to only have one line of therapy in the metastatic setting. Then they were randomized. So they were receiving the SG or the TPC as second line therapy, and we can see that on the top PFS and down the bottom OS, the OS went from 4.9 months with the TPC to 10.9 months with the SG. So even in patients who have the most refractory disease, the sacituzumab is non-cross resistant and can improve survival over our standard options, including eribulin, where we've historically used eribulin in this context. Very, very nice data. And then I had the opportunity to have a poster on the phase 3 Ascent looking at the survival for the individual chemotherapy agents on the TPC, and we see the green curve here is the sacituzumab, and the other curves all kind of bunched together for survival. So there was no one of the standard agents that really stood out with regard to survival. Response rates was 35% with SG, and were also only between 3 and 6% with the single agents. And the duration of response was 6.3 months for SG and was between 2.8 and 3.6 months for TPC. So no matter how you cut it, none of the single agents on the TPC arm really rose above any of the others in terms of benefiting patients. And the sacituzumab was clearly superior to them all with regard to survival, response rate, etc. So that is terrific, and that's moved up into the adjuvant setting now in TNBC patients who have not had a pass CR, being compared to either capecitabine or a platinum agent in the SASIA trial, getting into the curative setting. Well, there's a competition that's being developed now called Dato-DXd, datopotamab. And this is an antibody that also targets TROP2. But instead of having the SN38 payload, it's got the deruxtecan that we're very familiar with trastuzumab deruxtecan. That's the DXd. And this has been looked at 6 mg per kg every 3 weeks. And it's been looked at, looks very, very good in a non-small cell lung cancer expansion cohort. And so we, at ESMO Breast, we had the data on the tropion looking at the TNBC cohort. So these patients were pretty heavily pretreated patients, and 40 patients, and they had the 6 mg per kg. And the current analysis reported on the first 24 patients who had gotten either 6 or 8 mg per kg. And first of all, let's look at the toxicities. Even though both of the payloads are topoisomerase 1 inhibitors, the SN38 and the deruxtecan, there's very different here in the way of toxicity profile. You look down here, there's basically no hematologic toxicity, just like we see with trastuzumab deruxtecan, very different than the sacituzumab. It's more GI toxicity. There is some stomatitis, which we really didn't see with trastuzumab deruxtecan, about 13% grade 3 or higher, some no diarrhea and no ILD. So this is interesting, and this is going now into randomized trial. So we'll see, we'll await more data, but it certainly looks intriguing. This is the waterfall plot here. Like I said, kind of intriguing. On the right, we're seeing some of the patients are getting out beyond 4 months. It's still early days, but certainly highly active, as we have seen with the sacituzumab. Ladiratuzumab is another ADC that the ladiratuzumab targets LIV-1, ubiquitously expressed again on metastatic breast cancers, conjugated to auristatin, a very powerful microtubule disruptor. And when these cells die, when they internalize LIV-1 or the payload comes off and goes in and kills the cell dies via an immunogenic cell death. And so they combined the ladiratuzumab with pembrolizumab in the first line metastatic TNBC setting, and these data were very, very impressive. This waterfall plot, this was a well-tolerated regimen, and so it looks like putting the ADC here together with pembrolizumab, regardless of PD-L1 status here, looks very, very good. This patients, regardless of PD-L1, they had this kind of a result. So this is very interesting, is moving forward into a randomized trial. Now, our other friend, TDXD, has been shown over on the right in HER2 low, whether it's ER positive HER2 low or triple negative HER2 low, and whether the IHC is 1+ or 2+, we see that the trastuzumab deruxtecan has a very impressive waterfall plot here, even in a pretty heavily pretreated population. So we saw data at ASCO on the Begonia trial by Peter Schmid, and this is first-line metastatic TNBC, and so this is HER2 low. They're TNBC, but they're HER2 low, and they're getting TDXD with the checkpoint inhibitor durvalumab, regardless of PD-L1 status. Relatively small numbers here, but we see the PD-L1 positive is light blue and negative is dark blue, and we see a very impressive. So it's interesting, 2 studies now showing that ADCs, first-line metastatic with checkpoint inhibitors, regardless of PD-L1 status, look really impressive. So that's interesting, and we certainly need more data. We'll stay tuned to that space there. Turning now to the resistance pathways of AKT and PI3 kinase mutations. AKT is a ubiquitous method of resistance in triple negative breast cancer, and signaling through AKT can be upregulated by a variety of mechanisms shown on the right, and about 15 to 20% of TNBCs have an activating mutation in PIK3CA. A lot of times that overlaps with androgen receptor expression, but not entirely. So what can we do about these very important resistance mechanisms? Well, unfortunately, Opportunity 130 with ipatasertib, the oral AKT inhibitor, was a negative trial reported by Rebecca Dent at San Antonio last year. This was first-line metastatic TNBC. These patients were enriched. They were selected based on having a PIK3CA mutation or an AKT activating mutation or amplification or PTEN genomic loss. And it was weekly paclitaxel plus minus ipatasertib in this TNBC population, and unfortunately, there was no benefit at all. Very disappointing. We're still waiting on results of capivasertib, a different AKT inhibitor that's being looked at in an all-comers population, metastatic TNBC, not selected for the genomic alterations. Again, a paclitaxel plus minus capivasertib, so we will stay tuned to see if that's a positive trial. And Priyanka Sharma has led the way in looking at alpelisib in the metastatic TNBC patients. Shown here is a HER2 negative population, so it was a mixture of ER positives and triple negatives. These patients had usually about 1 to 2 prior lines, mostly 1 prior line of chemotherapy in the metastatic setting, and they were unselected for AKT PI3 kinase alterations, nab-paclitaxel plus alpelisib, a single-arm trial. And you see down the bottom in all 42 patients, it was a 59% response rate. And over on the right, in TNBC and hormone receptor positive, small numbers, but again, about 60% response rate. So that's pretty good. And we can see here in the waterfall plot that the red X's are PIK3CA mutations and the yellow X's are PTEN mutation loss. But other patients as well benefited, but it seems to be more of these patients, more of them had an alteration than not. And the dark black lines around some of the lines going down represents TNBC patients. So TNBC patients benefiting from nab-paclitaxel and alpelisib combination with a PIK3CA or PTEN mutation. And so there's a randomized trial now going on to follow up on this called the EPIC-B3 trial, a first-line metastatic TNBC patients with a PIK3CA alteration or PTEN alteration, the nab-paclitaxel plus minus alpelisib. So we await the results of that trial. I was fascinated by these data from Erica Hamilton at San Antonio last year. This is eganelisib. This is a PI3 kinase gamma inhibitor, not alpha, but gamma. Well, what does that do? It reprograms macrophages from M1 to M2, which are pro-tumor, to M1 macrophages, which are tumor suppressive. So macrophages are key because if you've got the M2 macrophages, it can suppress the activation of T cells. And so the eganelisib can switch these macrophages from pro-tumor M1, M2 to tumor suppressive M2 and help activate a T cell. So it made a lot of sense to do a trial of atezolizumab, nab-paclitaxel, and eganelisib in the first-line metastatic TNBC. Small numbers you see here, but this is very, very impressive, and it was regardless of PD-L1 status, and we can see that some of these responses on the right are getting quite long. So this is interesting. This might potentially help to warm up the tumors and turn some of the cold ones hot, perhaps, and get those bad macrophages out of the way and get the T cells activated. Very, very interesting hypothesis going forward. And then finishing up with trilaciclib. Trilaciclib is an IV CDK4/6 inhibitor. And in this small trial that Antoinette Tan and I were involved with, this is a proof of concept randomized phase 2. It was in TNBC patients, first, second, or third line. And it was a 3-way randomization to Gem-Carbo day 1, day 8, or Gem-Carbo with IV trilaciclib day 1, day 8, or giving the trilaciclib the day before and the day of each Gem-Carbo. And the purpose of this was because the CDK inhibitors can transiently arrest hematopoietic stem cell and progenitor cells and lymphocytes. It can stop their proliferation and hopefully preserve them in the context of cytotoxic chemotherapy. So that was the idea of preserving the immune system. But the other is that the CDK4/6 inhibitors can decrease the expression of FOXM1. And FOXM1 leads to DNA repair in triple-negative breast cancer. So if you can get rid of the FOXM1, perhaps the gem carbo would work better. And in the final survival analysis from San Antonio this past year, we saw that regardless of which arm, both trilaciclib arms had better survival, small numbers, than gem carbo alone. And so now this has gone forward into the PRESERVE 2 trial, gem carbo plus minus trilaciclib given on just the day of chemotherapy with progression-free and overall survival as co-primary endpoints. So that's kind of some new targets that we're looking at. I just wanted to finish with the case of my 49-year-old African-American woman who unfortunately is all too common in my practice. And she presented at 46 with locally advanced breast cancer, T3, palpable lymph nodes, hypertension, obesity, germline testing negative, preoperative AC followed by weekly paclitaxel carboplatin, had mastectomy, 3 centimeter residual disease, 3 positive lymph nodes, got PMRT, and 6 months of adjuvant capecitabine. A year later, she was undergoing deep flap reconstruction, and at surgery, she's noted to have cancer in the subcutaneous chest wall and in her right axilla, the plastic surgeon's calling, PD-L1 negative. Staging evaluation shows multiple pulmonary metastasis. She did not benefit from gem carbo. She had worsening right upper extremity pain. She lost function of her right upper extremity, swelling, this socked in local recurrence. Eribulin benefited her for 3 months. She did get improvement in pain and function, but her dose was reduced. So what treatment would you give her now upon progression on the eribulin? So she began sacituzumab. She's had a major response in her chest wall and axilla and her lung mets. Her right upper extremity pain is gone. Her swelling is way down. She can use her arm. She's required a dose reduction for neutropenia and has otherwise tolerated well. Excellent quality of life. She's about 6+ months out. And so I really want to ask Priyanka and Rita, we see this all too often, these patients who don't have very sensitive disease. Unfortunately, it does seem to be enriched in the African American population in my practice, and they come back with very substantial disease. What do you think? How can we make improvement? What do we have? Do you think that moving sacituzumab up into the curative setting will help these patients? And what are the key hypotheses we really need to pursue for this kind of really, treatment refractory type disease? What do you think, Rita?
Yeah, I mean, I have to say I see it so much treatment refractory disease in my clinic. I mean, I almost exclusively see triple negative breast cancers, not for any reason other than, patients coming for trials. But, I just think I've been excited and impressed with how much focus there has been in the last several years about developing trials around triple negative breast cancer and moving things forward for triple negative breast cancer. We've seen approvals for the PARP inhibitors, immunotherapy, now sacituzumab, specifically since we've been doing trials geared at triple negative breast cancer. But there is so much heterogeneity within triple negative breast cancer. And there's a subset of patients who do well and respond, but even those patients who and I have to say, sacituzumab has been a fabulous addition to our armamentarium. But even then, I have patients who have a very transient response to sacituzumab. And we need better therapies. We need new therapies. We need to better understand the biologic factors that drive the different subtypes of triple negative breast cancer. I think, as I've already alluded to, we're making progress with PD-L1 positive disease, maybe this basal-like immune activated subtype, but all of those other subtypes, there's still a lot of work that we need to do. There are going to be some trials coming out looking at enzalutamide and adding to that for AR positive triple negative breast cancer. But we're left with the mesenchymal like and a big chunk of the basal like immune suppressed that don't benefit from the addition of checkpoint inhibitors, at least based on emerging data. And we really need to better look at sort of the landscape of these tumors. There's a lot of work ongoing looking at the proteomic, not just gene expression level, but at the proteomics and whether or not there may be some actionable alterations there. And so I think there's a lot of work that's being done by really wonderful people. And so my hope is that we're going to identify novel targets for those that don't appear to have targets, at least by the methodology we're using now.
Thank you. Thanks a lot. And how about you, Priyanka? Any comments about these kind of just refractory and what you've seen with sacituzumab, even in these patients who haven't benefited from a whole lot?
So I go back to the case that you presented, and this is an individual. If the insurance carriers would allow you to, I would have tried to use sacituzumab even earlier on in the metastatic journey of this young lady. But as Rita pointed out, we see it a lot more often than we would want to, and these refractory cases. And my personal thought process on that is this probably represents the cluster of cancers that have neither immune upregulation nor HRD. So these are cancers, and immune upregulation and HRD might coexist in some patients, but it happens independently too. And each one of them provides at least sensitivity to some class of drugs. And when you have both of them being absent, then those are really poor prognosis cancers. And we presented some data at San Antonio that really separated these dual negative class into really poor outcome. And what we're starting to see that this dual negative class does have a higher proportion of patients that have PIK3CA mutation and PTEN loss. And perhaps that's a way to address some of these really bad tumors. And then also seems to be more enriched for targets that are in metabolism pathway, like AMPCK and certain other things. So it's going back to understanding this heterogeneity. You have immune upregulated tumors. You can address that with immunotherapy, chemotherapy, maybe immunotherapy, and ADC. And you have some that have some immune infiltration, but you can maybe augment it. But then these are these tumors that have neither chemosensitivity nor immunotherapy sensitivity, and we really need better research for these patients.
Diagnostic first, new targets, what's going on biologically, as you both said, absolutely. But we're getting some progress on some of the subtypes, and the sacituzumab certainly is there for hopefully making an impact in the curative setting as well, and using it as early as we can in the metastatic setting. Well, I just want to thank Rita and Priyanka so much for joining me here today and for taking us through data sets really updated from ASCO, both in early stage and metastatic triple-negative breast cancer. We've seen the new data from Olympia, which are practice changing for our germline BRCA patients utilizing adjuvant olaparib in those patients and improving disease-free, distant disease-free, and we hope as well overall survival. That was the biggest news from ASCO. We've seen very intriguing data adding the checkpoint inhibitor durvalumab to a standard preoperative chemotherapy regimen for TNBC, and seeing now with further follow-up, with mature follow-up, seeing improvement in disease-free, distant disease-free, and even overall survival. Very, very intriguing, particularly as we await the results of Keynote 522, which hopefully will take us to an FDA approval of preoperative pembrolizumab in the high-risk TNBC population. And we see that the data are emerging with sacituzumab that not only does it have an impact on overall survival in the overall intent to treat third line and later population, but it also improves survival in the most chemotherapy refractory population whose breast cancer recurs within a year of their curative chemotherapy. And they have an improvement in survival in the second line or later setting. And this is regardless of which of the treatment of physician's choice single agent chemotherapies. Every one of them were inferior substantially on survival compared to sacituzumab. And then we heard from Kevin Kalinske that even in patients 65 years of age or older, that there's a very nice improvement with sacituzumab compared to TPC with regard to survival in this older group of women. And of course, there are other advances in breast cancer at ASCO, but I've really enjoyed the opportunity to look together with my colleagues at the triple-negative breast cancer patients.
This activity is jointly provided by Medical Learning Institute Incorporated and Tiger Lily Foundation. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/EKR860. This activity is supported by educational grants from Gilead Sciences Incorporated and Merck & Company Incorporated.